Hey there, and welcome to the Reflux Revolution podcast. My name is Molly Pelletier, registered dietitian, leader in nutrition for GERD, reflux LPR, and founder of Flora Nutrition, and also a former GERD sufferer myself for over a decade. I have been where you are, and after years of struggling with reflux symptoms and feeling overwhelmed by conflicting advice, I've made it my mission to help you find real, lasting relief. In this podcast, we are cutting through the noise, providing practical, evidence-based strategies, and giving you the tools to understand and manage your reflux with confidence. Before we dive in, the information shared in this Reflux Revolution podcast is intended for educational and informational purposes only. It is not meant to diagnose, treat, or cure any medical condition, and it should not replace personalized medical advice from your physician or individualized medical nutrition therapy from a registered dietitian. Always consult with your healthcare team before making any changes to your routine. Your body is unique and your care should be too. We are in for a treat today, you guys. In this episode, we're diving into some of the most controversial and some of the most relevant topics to reflux. We're going to be discussing low stomach acid, histamine issues, MCAS, hypermobility with Dr. Zachary Spiritos. Dr. Spiritos specializes in neurogastroenterology with a focus on disorders like postural orthostatic tachycardia syndrome, also known as POTS, mast cell activation syndrome, also known as MCAS, and the gastrointestinal issues related to hypermobility syndromes. He cares for patients with IBS, functional GI issues, GERD, reflux, LPR, and complex motility conditions. He is passionate about patient education, whole person care, and he integrates nutrition, stress management, and gut-brain therapies into his treatment approach. So we are so lucky to have him joining us in this podcast today, answering some of your most pertinent questions about the root causes of reflux and histamine issues. So without further ado, let's dive in. Dr. Zachary, thank you so much for joining us. Super excited for this conversation.
Yeah, no, thanks for having me.
We have just been chatting offline about a very controversial topic, and I'd love to dive into this topic first because we had a ton of questions about it. And the question is, does low stomach acid cause reflux? And this is something we see, all the time on social media. And at Flora Nutrition, we actually don't use acid supplementation. We don't use betaine HCl. We don't use apple cider vinegar. So I'd love to hear from you kind of, about this idea of low stomach acid and reflux.
I'd be happy to dive in. And so let's talk, I think it'd be helpful to talk about like what reflux is. So GERD, the acronym is gastroesophageal reflux disease. And it's what happens is baked into the name that stomach contents and acid and sometimes bile migrate from the stomach up into the esophagus. Okay. And that creates symptoms. The cardinal symptoms of reflux are heartburn. We kind of know what that feels like, and regurgitation. And then you can have extraesophageal symptoms as well, like chronic throat clearing, dry cough, nasal congestion. Those fit in a family called LPR, which is laryngopharyngeal reflux disease. Okay. And so when patients come to see me in clinic for challenging to control reflux disease, we sometimes employ a test called 24-hour pH impedance testing. It's not delightful. We have to be sure this is the right thing before we recommend it because it is kind of a pain. Effectively, patients wear a catheter that lives in their nose and migrates down their esophagus into their stomach for about 24 hours and records how much acid migrates from the stomach into their esophagus throughout that 24-hour period. It also shows us non-acid events, so gas and liquid that is not acidic or alkaline coming up to their esophagus as well. And patients have the opportunity to press a button when they have symptoms. So when they have these symptoms, whether that be the heartburn, the regurgitation, etc., I know exactly what's going on in their esophagus at the time of those events. And at those time of the events, acid is migrating up from their stomach into their esophagus. Okay. So a low acid state would actually create the opposite, right? You don't have any acid that's coming up into your esophagus. So there are low acid states, okay? And these are gastropathies. So these can be due to kind of more severe H. pylori gastropathy, which is a bacteria that effectively kills off or makes these parietal cells that create acid in your stomach less abundant. So you don't really have any stomach acid. Or there's another condition called AMAG, which is aplastic or autoimmune metaplastic atrophic gastropathy, where there's an autoimmune condition that effectively it attacks your parietal still, so you're not able to make any acid in your stomach. So we know these conditions exist, and they do not really cause any upper GI symptoms. Occasionally, they can cause pain here, which is called dyspepsia, which is categorically different than reflux disease, which is kind of up in the chest region. And those conditions can cause vitamin malnutritions like low iron, low B12, low magnesium, but typically don't cause any symptoms. So I would say in my clinical experience, and from what I know of gastroesophageal reflux disease and what I know of low acid state, which I see also in clinic, that the latter do not cause symptoms of gastroesophageal reflux disease.
Super helpful. Thank you. Because it's scary how I've seen those supplements between apple cider vinegar actually really be harmful when taken, in the wrong context. And they can actually be, especially for those with LPR, really, really damaging. So thank you for.
But you bring up a good point, though. Why do digestive enzymes work for people, right? And I've thought about this because they do. They sell them at my gym. Like I see them being pushed and people take them. So why do they take them? So I don't think they work for gastroesophageal reflux disease, but I wonder if you do have something like gastroparesis, where food sits in your stomach for longer. Like people who have really challenging GERDs sometimes have comorbid gastroparesis, because your stomach, when it receives food, it's like a blender. It should churn up the food and push it into your intestines. But if it just sits in your stomach for longer due to gastroparesis, it is more liable to come up into your esophagus, leading to reflux disease. So I wonder if that's treating like a cohort of people with reflux, but I don't know. I still think it's kind of a waste of money. But I think, whatever floats your boat.
I think that's really important, and it brings up a good point about, understanding what are the real drivers of reflux. So what do you think are the most commonly overlooked drivers of reflux?
Yeah, so the most common ones are obesity, because what excess abdominal weight does, it puts undue pressure on that tiny little valve at the bottom of your esophagus called the lower esophageal sphincter. And so it just increases the pressure gradient between your stomach and your chest cavity. So food kind of migrates upwards. And we know that losing, 5 to 10 pounds really, really helps with reflux. And then the other one is a hiatal hernia. And so the lower esophageal sphincter is our innate gatekeeper for reflux and stomach contents from your stomach into your esophagus. And that becomes mechanically weaker in the context of a hernia. So those are the two most common causes of reflux symptoms that I see. But then there's diet as well, which we certainly can't overlook.
Yeah, diet for sure, which we talk a lot about on this podcast. How do you distinguish between structural, you mentioned hiatal hernia, potential lower esophageal sphincter issues, versus functional or more inflammatory causes?
Yeah, it's a really good question. That's a tough question to answer. But so when patients don't respond to traditional reflux therapies, or their reflux is kind of not behaving typically, and they have a lot of extraesophageal symptoms, we will do these pH impedance testing. And in those tests, what we see sometimes is we see that patients press the button a lot when they have symptoms, but yet nothing is happening in their esophagus. And that's when we typically refer people as having either functional chest pain, which means they have chest pain, even when their cardiac testing is negative, but they have chest pain and nothing is happening on the pH test. So nothing is coming up in their esophagus, but yet they feel something going on there. The other category of kind of functional hypersensitivity is patients who have normal amounts of reflux disease, but yet they feel it all the time. So we all have reflux throughout the daytime. It's just a small amount. But when they get it, they feel it a lot. Okay. So they do have not pathologic amounts of reflux, but when they have reflux, they certainly feel it. And that's a different diagnosis in and of itself. But I will say, if someone has a hiatal hernia, I'm typically chalking their symptoms up to reflux until proven otherwise, until we put you on therapy, whatever that may be, and then do a pH test. And if there's nothing coming up, no acid, no non-acid reflux coming up, and you still have symptoms, that's when we say, okay, this may be a functional etiology.
Yeah. So as a registered dietitian, when someone has been diagnosed with functional reflux or functional heartburn, we are looking to, support and reduction of inflammation if those tissues might be inflamed, but also nervous system support if those nerves are hypersensitive. What are some of your first steps if they have functional reflux?
Yeah. So let's talk about why it happens. Okay. So when someone has functional discomfort in their chest, it is an aberration in the brain-gut interaction. Okay, so either your esophagus is sending reflux symptoms to your brain that then your brain is not able to tune out. Okay, so our brain and our spinal cord is able to kind of tune out signals that it doesn't need to hear. That's called the gate control theory. Okay, or it's a top-down process where you get stressed, you get anxious, you're in sympathetic overdrive, and that's causing pain. Okay, and I typically think of the functional heartburn, the reflux hypersensitivity, where people have reflux, but they feel it more, as the former, where their spinal cord is just not able to tune out those signals. And then the functional chest pain, people just have chest pain all the time. It's not their heart. There's no reflux going on at the time they have symptoms. That's what I think is more of a top-down process. So we talk about, how do we divert our system from sympathetic to parasympathetic modes? And that's really, really tough, and that's individualized. So, the number one thing is getting good sleep. So I talk about sleep all the time in clinic. And the very same reason that people are feeling everything more, that overactive sympathetic drive, that often keeps people up at nighttime. So there's a lot of comorbid insomnia in a lot of these people. And we talk about exercise, getting outside, being around loved ones. And then we sometimes use pharmacotherapy as well. So we know that SSRIs actually can really help with the functional chest pain. And then SNRIs like Cymbalta or TCAs like amitriptyline that are also used for neuropathic pains like migraines, diabetic neuropathies, complex regional pain syndromes. Those help your brain tune out those signals. And these medications are not forever. We're not necessarily using it for anxiety and depression. If they exist, we can use that. Some of these medications help people sleep. So if there's comorbid insomnia, we can use that. We can use them as well. And we don't take them lightly. I'm not handing them out like candy. It's a shared patient decision process if this is the right medication for you. And we don't use this forever. We usually, in 12 to 18 months, we try to wean people off this medications. And oftentimes we're successful because we take advantage of neuroplasticity. So after the brain's able to tune out those nerve signals for a while and you stop feeling that pain, you're able to wean off that medication, often successfully without recrudescence of that pain. So it's kind of a cool thing, but it's not easy, right? This is not a set it and forget it. It does take a lot of hand holding and a great relationship between the physician and the patient to execute this in a way that we're successful.
Love it. Love all that. How about hypermobility syndromes and GI issues? What's the connection there? Can you explain that a little bit?
Yeah. So hypermobility is where there is innate defect in the collagen synthesis. So the collagen is the scaffolding for our whole body. The ligaments, the fascia that hold up our organs. So everything kind of sags a little bit more. And people are also prone to hernias. So it can affect, collagen is part of every element of our GI system. So starting in our esophagus, people can have slow motility of the esophagus called ineffective esophageal motility. They can have hernias even at a really young age. We typically see them later in life, but you can develop them early on. A lot of folks often have comorbid gastroparesis where the stomach moves a little slower. And the small bowel, they may have small bowel dysmotility as well, setting them up for something called SIBO. And their colon may not work either, called colonic inertia. So everybody's presentation is unique to them. And you have to take into consideration, okay, are they hypermobile? And then you have to kind of keep you have to be aware of the unique challenges that they face. They also have vascular compression syndromes like median arcuate ligament syndrome, which is a whole conversation in and of itself, which can cause a lot of pain after eating. They also have a lot of pelvic floor issues where, their colon is squeezing okay, the poop is nice and soft, but goodness, the back door will not relax adequately for stool to evacuate because everything just kind of sags. And they also can have rectal prolapse. So it can affect really any part of the GI tract. So when we see folks with hypermobility, certainly we tailor the conversation to their specific needs because they often can compound diagnoses that don't affect people that don't have collagen kind of mishaps with their connective tissue.
I know this is going to be so refreshing for those with hypermobility syndromes and with reflux hypersensitivity to just hear a doctor talking about these things, because I think that the experience is so often that patients will go to a doctor and they've never heard of these things. So it's really great that we're talking about it. Another issue that I think is not, we're really widely understood is MCAS and the histamine connection. And so how do histamine and mast cell activation contribute to reflux or LPR?
Yeah, no, that's a really good question. And so if we think about the parietal cell, okay, that's located in the gastric body, and that's what secretes the acid into our stomach. Okay. So one of the receptors on the kind of mucosal side, I'm sorry, the non-luminal side is histamine. So if histamine is secreted in excess, it can bind to a parietal cells, which then secretes acid. Okay. So PPI is really good at plugging up the parietal cell if taken appropriately and can help with reflux symptoms. Okay. So if you have mast cell or histamine intolerance, where you just have an excess of histamine in your system, that excess histamine can bind to the parietal cell and just cause a ton of acid secretion from the stomach. Okay. But not only that, but the mast cell activation syndrome can actually, it's a direct inflammatory process of the gastric body and the esophagus. So people actually just have pain, even if their acid reflux is under good control, and it feels like heartburn. So histamine also causes sensitivity of those nerves that innervate this area. So people get a lot of visceral hypersensitivity as well. And so the classic story I hear is a young person without any obvious risk factors for reflux disease. They're kind of slender build, or even if they're not of slender build, and they're just young. They don't have a hernia, and they just get this rip-roaring heartburn that lasts for hours on end, and like seemingly like without reason. Like they just ate some Cheerios or ate like a tomato, which mind you, the tomato can cause reflux, but goodness, this lasts for like 10 hours, and they're exhausted and they have brain fog, and it sounds like reflux. So people put them on PPIs and hit them with PPIs, and they're not responding. And they're, goodness, doc, I have reflux. And my answer is no, you don't. You have something else. And then you dig deeper and they have brain fog and fatigue and palpitations. So yes, it can manifest as kind of all the reflux symptoms, but it behaves differently. People don't have traditional reflux risk factor for reflux. It doesn't respond necessarily to reflux therapies, and they have all sorts of other symptoms as well.
What are your first steps in assessing histamine issues?
So there's histamine intolerance and there's mast cell activation syndrome. And so histamine intolerance is where the body's ability to process histamine is not as sufficient as it used to be. And that may be due to a deficient or defunct enzyme in the intestinal lining called diamine oxidase. So you eat a meal that's high in histamine, whether that's kind of aged foods, aged cheeses, leftovers, and when it gets absorbed, that histamine is not degraded into its inert form, which is not bioactive. And histamine is able to kind of run amok in your body, causing palpitations, flushing, fatigue, a whole host of diarrhea, nausea, bloating, etc. So a lot of symptoms that affect multiple organ systems. And histamine intolerance is primarily postprandial, so after eating a meal that's high in histamine. Mast cell is where these cells called mast cells, which are innately very healthy or helpful for us. They help with tissue healing and evading pathogens like viruses, bacteria. So do a lot of really good things for us. And when they are intentionally and at the right time told to elicit their chemical mediators, they do a lot of good stuff for us. But in mast cell, they're just eliciting their mediators all the time, or to various stimulus. So it's not only to food, may not be to food at all, but to temperature changes, pressure changes, pain, insomnia, stress, mold, like you name it. And so people are getting all these symptoms, but not necessarily related to mealtime. So if it's postprandial after eating a meal high in histamine, then we typically think of histamine intolerance. But if it's just kind of, you get all these symptoms that are seemingly random, or, are you're just so sensitive to everything, then we think more of mast cell activation syndrome. But they can cause similar symptoms, but do have different treatment plans.
Super helpful. So maybe we can, for each condition, maybe we can talk about like ways to support histamine balance for histamine intolerance, or histamine breakdown, detoxification for histamine intolerance, and then how would you then first steps in supporting someone with mast cell?
Yeah, so the first is to eliminate the triggers. So in histamine intolerance, you really want to kind of dial back on the histamine that you're eating. There's a lot of good resources online. But to start, it's aged foods, aged cheeses, wines, beer, fermented foods, and leftovers. So leftover, if you're cooking a meal, you got to eat it right away, or you cook it, you freeze it, and then you heat it up from freezing. Because if it's in the fridge, that food the bacteria there will start fermenting the food into histamine. Okay. And then we can use diamine oxidase as well. It's not, It works pretty well. It works pretty well. I wouldn't say it's 100% effective, but I think the main thing is identifying the dietary triggers. And then you can use H1 and H2 blockers to block the downstream effects of histamine in the body. So H1 blockers are medications we traditionally use for allergies, whether that's Zyrtec, Allegra, et cetera. And H2 blockers are Pepcid for motility. And we use really high doses of these medications. Our goal is to have adequate symptom control with minimal medications as possible. So often we'll start these medications if I'm suspicious of it. And if you're doing well, then we start kind of tightening the screws in terms of what we can do behavior-wise to minimize the amount of medications as possible. Okay, mast cell activation syndrome. This is a tricky issue. So everybody's mast cell is unique to them, and everybody's triggers are unique. So identifying triggers is first and foremost is paramount, but it can be really, really tough. It could be, the perfume that your significant other uses. It could be, where you live because it's at a high pressure zone. It could be the mold in your house. It could be the weather. It could be stress. There's so much. It could be an autoimmune milieu. If you have rheumatoid arthritis and psoriasis, it could be just an autoimmune phenomenon. It could be your POTS. It could be dysautonomia. It could be hypermobility. So it's really, really tough. But you have to try to identify the triggers as best you can and isolate them. We're not always successful. So we often pair that with mast cell stabilizing medications. And there's a whole host of mast cell stabilizing medications that one can use based on who you are, kind of what your symptoms are, your comorbidities. So I always start with Pepcid and Zyrtec to start H1, H2 blockers because that does just block the downstream effects of histamine. Doesn't stabilize the mast cells per se, but Cromolyn is nice for GI symptoms. Ketotifen is one. Low-dose naltrexone is one. Singulair is one, but they all have their unique benefits and drawbacks. You just have to kind of work with a physician who has treated MCAS so they can kind of help understand what symptoms we're trying to trigger, who you are, what can we use, and tailor therapies that way. But there's a good amount of over-the-counter options that one could use. Quercetin is a nice one. High-dose vitamin C at 1 gram twice a day. There's a proprietary group of flavonoids called Neuroprotect. That's a nice one. Low-dose naltrexone, and then even like microdosing GLP-1s is actually shown to be beneficial. THC, if you're in the right state. I'm in North Carolina, it doesn't really work so well. But yeah, there's a lot of options out there.
Super helpful. Super helpful. So are there any labs or tests that those who suspect these types of issues should ask for, or any specific questions they should ask their doctor?
Yeah, so MCAS is tough for so many reasons. There's no FDA approved medications. We're borrowing medications from other specialties, and the testing is imperfect as well. So there is a tryptase test, a serum test, which is not incredibly helpful. And when it's high, it's great. If it's not, don't really care. There's a couple 24-hour urine collections that we can use that really just measure the chemical mediators of mast cells. And those are typically done at academic centers. So when I was at UNC, we can certainly order them. And some of those are N-methylhistamine, leukotriene E4, 2,3-dinor, prostaglandin. So there's a couple helpful ones, but even if it's negative, I'm not sure I care if the shoe fits. So it's somewhat of a putative diagnosis where it's kind of based on hunch and just making sure there's not anything else that could be causing all of these symptoms. And rarely can you identify something that can cause all these unique symptoms in different organ systems. So if they're negative, the sensitivity is about 50 to 60%. So it's a coin flip as to whether they'll detect your symptoms or not detect your symptoms, detect whether you have MCAS. So I don't put a lot of weight into that, but I will, we certainly send them out because when they're positive, they're helpful.
This has been super, super informative. Do you have any last favorite tools or strategies for either those with histamine intolerance, MCAS, or the hypermobile folks? We haven't necessarily touched on that yet in terms of supportive strategies.
Yeah, I think it's identifying someone who can partner with you on this because it is a teamwork. It is a team. It really requires a partnership between a doctor and a patient because you're playing Sherlock Holmes, right? You're trying to identify what your triggers are and then what specific medications you can use to stabilize the mast cells. And you have to do that with a partner, right? So I had a patient this morning who's trying these H1, H2 blockers, but she's reacting to every one of them. So she's now sending them to me. I'm trying to figure out what the excipients are in the medication. So the little additives in the medication. She's not responding to Pepcid. It's the other schmutz in there that's preserving these stupid medications that's making her react. So we're trying to go through these lists to figure out what she's reacting to. And it's a dance, right? And you got to have someone who's invested because you can't do this alone. And on top of that, a symptom diary is really helpful. Sometimes it can be futile because there's so many triggers. And sometimes when it doesn't make sense, it's helpful too, because it just means we have to rely on medications more than avoiding said triggers. So yeah, those would be my tips.
Yeah. Wow. Well, thank you so much for your time. This has been awesome. If people want to find more about you and your work, where should they go?
Yeah, you can find me on my Instagram, Dr. Zach Spiritos, and our clinic is Ever Better Medicine. If you want to, if you think we're right for you, we'd love to see you.
Yeah, everyone who's listening, you got to go check out Dr. Zachary's Instagram. It is actually hilarious. And if you struggle with some of these issues, you will definitely resonate with what you see on his Instagram. So definitely go check that out. Well, thank you so much, Dr. Zachary. This was great.
Yeah, absolutely. It's a lot of fun.
Thank you for joining us for this episode, my friends. I hope you enjoyed it. If you did, let me know. Leave us a review. That really helps people find this podcast who are struggling with reflux or digestive issues. Share this with a friend who might benefit or is also struggling with reflux, and make sure you subscribe so that you stay up to date for our weekly episodes. Thank you for being a part of the Flora community, and I'll see you in the next episode.